This is the second part of the series on forefoot pain, and we've had the anatomy, which included a good part of the exam actually. And so we're going to be redoing the exam now without the anatomy lesson. And this will include the whole body. So John would be actually assessed objectively in his gait cycle, standing as well as balancing, all three. So he'd be in static and functional dynamic positions. And that would be assessed on his gait length, stride, anything that would be a compensation from his pelvis on down, even his shoulders. All these have an influence on your forefoot pain, so you wouldn't necessarily eliminate them. The other part of the exam that we have to clarify a little bit would be the subjective, and that'll be important as you get into forefoot management. Forefoot pain is fairly complicated as we're dealing with people that often overuse their forefoot. And this would be athletic or vacationing people, or people that have the wrong footwear, and people that have anatomy problems that lead to forefoot situations that can be more stressful than others. So part of your exam is going to be definitely including nutrition, their volume of work that they're doing with their feet, how much they're on their feet, what a surface is that they're on most of the time, how frequently they're taking breaks, how often they take different types of activities in their sporting life so that they're not doing the same event over and over, how much speed they're using, how much volume they are putting into the work cycle for each week, how fast they're moving, what type of shoes they're wearing, what type of surface they're running on, and what type of level or uneven ground they would be on. If they're doing habitual side running on slopes of roads, or running the circle the same way in a lapped type of running, or what type of treadmill they're using, what type of footwear they're using, how much padding they're using, all these contribute to your understanding of the forefoot pain. So in John's situation here, we're going to assume that his forefoot pain is not due to health-related issues. He's not either hypersensitive or hyposensitive. His nutrition is good. He's maintaining a good sport balance in his life, and he's not excessively running or excessively on his feet with bad footwear, but we'll get into that in the later sections. So if John could stand now, the exam would already include walking and, if need be, a running analysis on a treadmill with videotape. But in this case, John will balance on his right foot and squat down and try to maintain that balance. Again, what you're looking for very carefully is how he does his organization for his motor control. Is he using his arms? Is he using his pelvis? Is he using his forefoot in forward flexion or extension? Are the toes engaged for flexing to gain his balance? Is he tipping excessively on the outer foot or the medial foot, the inside foot? How much of his blanching do you notice on his toenails? How much clawing do you see with his distal tips of his toes digging into the carpet? All of these suggest weaknesses or balance strategies that might lead to some forefoot pain either on the inside or the outside. In this next position, the pause of him balancing will be stopped with him integrating rotation of his trunk. So he'll turn his shoulders and his waist to the right. That's testing hip internal rotation, but it's also testing his ability to balance on his foot. Turn his trunk to the outside now. And towards his left, we'll test his right external rotation, as well as his ability to maintain that rotation on a balanced foot. And then rising up on both feet at the same time, we'll test his power as well as his comfort for putting pressure directly over his fat pad, plantar calcaneus, less but more forefoot, more. And with the pes cavus foot, they're always going to be harder on the forefoot than the arch. So he's actually a pes cavus patient, and he's doing quite well with no pain. He's not shifting from one foot to the other, trying to avoiding pressure off one small area. Now John is on his back, and we're actually thinking about the components of forefoot pain that could be assessed in this position. Some of those would be his forefoot mobility with his toes coming up into extension to see if he has full pain-free toe extension passively. We could also measure that first great toe dorsiflexion or extension to see how much this would give him for range, for propelling himself along. And you'd like to have at least 60 degrees on this great toe, which John easily has. We also check the lesser toes to see how mobile they are. And we check the flexion again to see how comfortable that is and how much mobility is present. In this position, we are also interested in relative balance of foot. The balance of the foot would be a rear foot neutral, assessing how his forefoot is aligned in this dimension with his rear foot neutral. John's got a plantar flexed first ray. So when his rear foot is in neutral position, his forefoot is down 15 degrees with his great toe down approximately at least 3/4 of an inch from its fifth ray. So that means he's excessively loading his big toe side when he runs or walks. The other thing that would be a good item for predicting forefoot pain would be flexibility of the muscles of the rear foot. So this would be ankle dorsiflexion in the knee extended position to see how much angulation that you would like to have 15 at least, and John has 10. We could also in this time measure plantar flexion, supination inversion, eversion, and have that as a comparison to his other side. It's also very helpful to know if John has more anteversion or medial rotation in his hip, or external rotation or retroversion, which makes him more pressure on the lateral foot. Also, genu valgus in this position is going to give him more pressure on his medial toe, and genu varus will give him more pressure on his lateral foot. Okay, now we're dealing with John in the lying position and assessing his sensory provocation of his foot and his capability to detect light touch. We're going over the dorsum of his foot, and if you could bring your toes up, checking the extensor digitorum and let your toes go down. And right close to the talus, a little bit further down, we're just stroking over the cutaneous nerve for his forefoot. We're also coming down right next to the joint with his proximal metatarsal, where frequently you'll get a bossing of bone at this joint or a saddle deformity of bone, forming a little beak, and the nerve goes right over that beak on his medial great toe, and that's the perineal sensory nerve. Coming down into this area, we've already talked about the palpating of the nervous system in his forefoot. For strength, I like to use Kleenex that I make into a little rope, and then I ask the patient to go ahead and try to prevent me from pulling the Kleenex up. And John tears that, which is normal for me. Again. Again. And you compare that to each side. When you have forefoot pain of neuroma style, frequently you're going to find that your interossei lumbricals are weakened, the short muscles of your foot, and you have dominance with your long flexors. So they actually have calluses frequently on the tips of the toes because they're digging in with unopposed lumbrical and interosseous weakness. So this patient is strong, and he doesn't have any problems with compression shearing of his forefoot. But frequently when you have forefoot metatarsal pain, you'll find weaknesses and imbalances in your long flexors and your short stabilizers. To measure sensory, we use the Symes-Wenstein monofilaments, and this set is from Carville for the Hansen's Disease Center, which has kind of sentimental reasons. I've kept this set for the last 25 years. Going ahead and pressing down lightly. And if a patient feels that we tell them to say yes when you tell them where you're touching. Do you feel the fifth toe?
No.
We go on to the fourth toe.
Yes.
Third toe.
Yes.
Second toe.
Yes.
Large toe.
Yes.
Then we go back to the one he missed. Fifth toe.
Yeah.
And that's pretty common, that they're not ready to be calibrated for that light touch. So just say yes, okay, and come back to it, and you'll find that they can feel it because now they've kind of figured out how lightly it's going to be. Also do the bottom of the toes, and you can do at this time the inside, outside foot, top of the foot, and if need be, move your way up. Okay, at this point, we've figured out the position of his foot in relation to his tibia. We know how functionally he's using his forefoot. We also know how the sensory and motor power is for some of the muscles, but not all. But we're moving on for time reasons. We're finding that if John had a pain in one of these areas, and we found it with our palpation, we're going to put lipstick on that area, and whatever shade is you've got that nobody else wants would work fine. This one's almost done, actually. And this next stage would be to take something out of his shoe, like the liner inside his shoe, and in this case we're just going to use a piece of cardboard. If John, you could stand on that cardboard. So John could be standing on his own liner of his shoe or the impression tray, in which case he'd be sitting down and just putting the weight of his foot on the top of the impression tray. In this case, we're going to just trace his foot and have him kiss the cardboard just by squiggling his foot on the board. And that's good. You can go ahead and sit down, please. And now we have the area identified that's painful on his liner or the top of an impression tray. And we'll use that to guide how we want to relieve and take pressure off that one particular area. And the final point is, don't forget to give your patient some Kleenex to take the lipstick off his foot before you have him stand up. This has caused me some problems over the years, and I finally gave up and got carpet with spots all over it.